Diagnosing and managing multiple sclerosis is very much clinically driven. It's all too easy to rely upon tests, MRI, lumbar puncture, maybe some other tests, evoked potentials, blood tests, but fundamentally you have to examine the patient. You need to be confident on clinical grounds who has MS, who has relapse, and who doesn't. The simple rule is, if a person has symptoms of MS, then they must be abnormal to examine. The exception is sensory symptoms alone, which of course are relatively benign. But people can have sensory relapse of MS without being abnormal to examine. That's a tricky one. But if someone has trouble walking or with their vision, then there must be something to find when you examine them. I would like the delegates not to be the sort of doctor who makes a diagnosis by taking a test and then communicates the result to the patient and the GP. The neurologist should offer an opinion. Anyone can order a brain scan or do a lumbar puncture, but interpreting the data is difficult and only meaningful in the context of the clinical findings. Once a person has a diagnostic label, whether it's MS or epilepsy or Parkinson's, it's very difficult to undo it. I'm afraid that there are some doctors who are a bit quick to make a diagnosis. Often better to say you're not sure and it's like this, but you need some more time or some more data to make a diagnosis. If with the fullness of time you begin to have doubt about that, then the first thing I think to do is to find out whether the patient wants to unpick the diagnosis. And sometimes they don't, and it's just meddlesome to do so, and you have to allow people to have an incorrect diagnosis. Not happy about that, but it happens. If the patient wants to work with you, then really the key thing again is examination. Does it look like MS? Does it fit? If it doesn't, go back and see what examination showed previously. Was the patient examined at all? Was it recorded? What did they find? Look at the tests. Are we sure that the MRI was truly positive, or maybe it was non-specific, just a few UBOs? Are we sure that the CSF showed what it is said to show? The letter may incorrectly record what the lab had communicated. So go back as far as you can to original data. When we think about incorrect diagnosis of MS, we mostly think about people who have symptoms which are diagnosed very late and are then cross that they've missed out on a diagnosis and possible treatment. Remember that the diagnosis works other ways, so be sure that there is no other neurological disease. We hear from those with MS who have a slow diagnosis. What we don't hear from is people who might have had MS but actually had a disc prolapse or a spinal cord tumor or a funny form of chronic migraine. Within MS, there's a big differential diagnosis. How do you distinguish relapse from normal ups and downs or from pseudo-relapse? How do you distinguish relapse from progression? And noting that unexplained symptoms are the commonest differential diagnosis of MS, people with MS also have unexplained symptoms, probably more likely to do so because of frontal lobe change. So not every symptom that occurs in a person with MS is part of the disease. One has to be careful and picky about that. The management of MS is fundamentally clinical, augmented by tests, but clinical method rules.